Minasan konnichiwa. Today I would like to share with you uh, strategy to enhance average LAT for treating hypoxic radioresistant tumor. Uh, this presentation content will be as shown introduction and then briefly background about the topic. Then we are reviewing a published paper. Then we conclude. So it is very well known that carbon ion improves tumor targeting capability due to less serious scattering in the spread out Bragg peak. Additionally, carbon ion offer a biological advantage compared to photon or proton due to their higher LAT, which induce more complex, non-repairable DNA damage, larger biological effectiveness in cell damaging, larger biological effectiveness in cell damaging, uh, make carbon ion a better option to treat hypoxic radioresistant tumor, such as a pancreas tumor. However, currently, clinical planning and delivery methods for patients' treatment with hypoxic radioresistant tumor, such as pancreatic tumor, do not yield enough high averaged LET in the target volume. Value in patients are considered to be low to mid-range values for this averaged LET. Therefore, strategies to enhance averaged LET are widely investigated in the field of particle therapy. Current clinical planning and delivery method for patients do not yield enough high average LET and tumor targets. Values for this averaged LETs can be expressed as minimum, maximum, and averaged LET. Those values are strongly changing with tumor volume and beam arrangement. Averaged LET typically reach a value from 30 to 50 kV per micrometers, and it is very recommended to accomplish a minimum average LET of 44 kV per micrometers to improve local control. Nowadays, many strategy in particle therapies concentrate on increasing average LET on gross tumor volume with respect of the biological dose and average LET while maintaining a low toxicity profile for organ at risk. Those are three approaches for average LET enhancement in particle therapy. Multi-ion therapies, where both lower and higher LET particle beams are combined in a single treatment session. It is an incredibly great approach, but the number of facilities to make such an approach is very limited around the world. The spot scanning hardened arc therapy is a method that delivers a conformal dose to the tumor while protecting the surrounding tissues, healthy tissues, by receiving lower dose level over larger volume. Lower dose level over larger volume. And simultaneous integrated boost, where the tumor subregion receive a dose boost more than any other region. I would like to share with you two papers or two studies to address these two approach, these two methods, spot scanning and simultaneous integrated boost. This paper aimed to show the spot scanning hardened arc strategy to verify average LET boosting using anthropomorphic pancreatic phantom. Anthropomorphic pancreas phantom. At HIT were used to verify different plans, and the results were compared to treatment planning system. They optimized using 3-beam configuration, 2-beam and 3-beam and spot hard arc configuration. So using this multi-field optimization, 2 MFO, 3 MFO, and spot scanning hardening arc were used to maximize the averaged LET, to maximize the minimum value of average LET within the gross tumor volume, and to verify the average LET posting for spot scanning hardening arc strategy. There are 2 different volumes were delineated and considered as planning target volumes. Those volumes are cylindrical for BTV, and another one including or representing the head of the pancreas and the phantoms. So those are the 2 different volumes which were considered for planning target volume, BTV, cylinder with 2 centimeter radius and 6 centimeters height, as we can see. And the other one is the head of the pancreas and phantoms, which contain a pluggable insert where an ionization chamber can be placed and insert for dosimetric measurement. By narrowing 5 millimeter in all directions, by narrowing 5 millimeters in all directions for each planning target volumes, the clinical target volume was derived. And once again, by narrowing 5 millimeters for each clinical target volume, the GTV, gross target volume, was derived. So they use multi-field optimization for 2 posterior beam plus 2 posterior beam and 1 interior beam. Also, the spot scanning hardening arc plan delivery, which use 20 beams spread equally along 360 degrees. So this table here is an evaluation of optimization for the cylinder and pancreas in the clinical target volume for this approach, and it display for 2 multi-field optimization for the cylinder. We can see that 67% of the scenarios passed with 95% of the clinical target volume receiving 3.A gray, while for the pancreas shaped, for the pancreatic or pancreas shaped, 95% of the scenarios passed with 95% of the clinical target volume receiving dose more than 3.8 gray. In the case of the 3 multi-field optimization and the spot scanning hardening arc for both the cylinder and pancreas, 67% of the scenarios received dose received clinical dose more than 3.8 gray. 67% of the scenarios. And this show a mean deviation of the configured plans of approximately 4% for both the cylinder and pancreas plans, which indicate that the deviations was higher than those absorbed in the 2 multi-field optimizations for the physical dose plan, So 3 main plan category can be distinguished based on this objective function. Uh, Based on this objective function, the three main categories can be distinguished are RBE weighted dose, physical dose, averaged LET. And when two beams were used for plan optimization, the high averaged LET can be absorbed on the tumor distal edge. For the two multi-field optimization, the average LET was 73.1%, 73.1 kV per micrometers for the cylinder target, and for the larger pancreatic shape target, the average LET was 63.5 kV by micrometers. For three multi-field optimization, the average LET was the average LET for the three multi-field optimization was 75 kV for both cylinder and pancreas. And lastly, for the spot scanning hardening arc, the average LET was 91.2 for the cylinder and 76.3 per micrometers, 76.3 kV per micrometers for the pancreatic shaped volumes, this one. As mentioned previously, all plans were optimized to deliver a uniform physical dose and RBE weighted dose to the planning target volumes for both cylindrical shaped volume or target and for pancreatic shaped volumes. So by looking at this two multi-field optimization, we can observe that the average LET on the cylinder shape is higher than the pancreas shaped volume. And that indicates that the volume change lead to different averaged LET volume. 73.1 for the cylinder, and it is less for the pancreas, 63.5. Also, a high averaged LET is mainly absorbed in the tumor distal edge. And by arranging the beam, adding an interior beam, the three-beam averaged LET optimized plan, it leads to an equivalent of averaged LET in the GTV, gross tumor volume, 75 for both cylinder and pancreas shaped. And this additional beam allow a higher average LET boost, 75 kV. So it's equivalent here. For spot scanning hardened arc plans, the cylinder target received the highest average LET value in the gross tumor volume than all the remaining plans. However, as the shape change again, shapes is in the pancreas volume, the average LET become less than 76.3. So in the cylindrical volume, it was 91.2, and it became less to 76.3 due to the change of the shaped volume from the cylindrical to the pancreas. Spot scanning hardening arc, however, plans effectively provide conformal dose coverage while concentrating the high averaged LET at the tumor center. So moving to discussion, two beams configuration allow to increase the averaged LET within the tumor. However, the boost in averaged LET was not only limited to the tumor distal edge, it is also come with a higher entrance dose higher entrance of physical dose as well, which can also potentially impact normal tissue. Um, the three beam configuration, two posterior and one anterior, allowed to increase average LET within the tumor. However, this boasts an average LET compared to the two beams can show less entrance physical dose, but it is not commonly used in clinical pancreatic treatment due to the increase of sensitivity to anatomical change, particularly because of the respiratory movement or because of the GI in the body. So spot scanning hardening arc plans, this plan, spot scanning hardening arc, concentrate the high average LET at the GTV volume, which could potentially benefit the treatment of hypoxic radioresistant tumor, uh, such as the one found in pancreatic tumor. But spot hardened arc plan resulted in the higher average LET volume and the gross tumor volume than all the remaining plan. However, radiation time takes 20 to 40 minutes, and range uncertainty lead to a large deviations in physical dose, as it was shown in the table before. And it also show higher deviations between the expected and measured physical dose compared to the other plans. The other approach or the other method or strategy to enhance average LET for hypoxic tumor is a simultaneous integrated BOSP. This paper show 4 generated simultaneous integrated BOSP plans based on the re-optimization of the original plan. And they use the same angles and primary targeting the prescription and the volume. It aims to evaluate the averaged LET and does at the oxygen enhancement ratio and at the target too. So 3 45-degree beams were arranged to compare each simultaneous integrated BOSP plan with the original plan. Beams were arranged from two sides, right and left lateral side of the body, and one from the back through the spinal cord. All plans, the 3 beams with the 45-degree, and the modulation parameters are target, volume, location of the target, and the prescribed dose. So plan 1 and plan 2 and plan 3 have the same prescribed dose, 75 grays, but different target volume. Whereas plan 4 has the same target value as plan 3 and different prescribed dose, 100 gray. Those plans were created to increase the Bragg peak density by adding higher dose. Therefore, more Bragg peak was included in the modulated targets. And it showed that averaged LET can be modulated to be higher in a small target, such as the GTV core, than in larger target volumes. To control local advanced pancreatic cancer, a minimum average LET of 44 kV per micrometer to improve local control is needed. And addressing how the modulation target size and the prescribed dose to the target volume impacts the average LET, defining the modulated target and evaluating the percentage of the volume for those receiving more than 44 kV are defined. So 100% mean that those received 44 kV per micrometer. And the definition of this modulated target, for example, MBTV1, it is defined when the GI was overlapped with the planning target volume, or for the GTV core, it is defined when the GTV, gross tumor volume, shrink to 10 millimeter uniformly in all directions. It shrink to 10 millimeters. Plan 1, Plan 2, and Plan 3 have the same prescribed dose, but different target volume, modulated target volume, specifically to this simultaneous integrated post plan. Plan 4 has a different prescribed dose, yet the same target volume as Plan 3. The result show that RBE weighted dose for average LET and oxygen enhancement ratio and the gross tumor volume in this table, and in the gross tumor volume core for the original plan, and also for the modulated plan. So the modulated volume, as the modulated volume here decrease, averaged LET can be modulated to be higher in a small target than in a larger target. See, we can see most significantly at the 44 kV per micrometers. As we compare the original plan, it increased in all modulation plan in both JTV and JTV core. Especially in plan 4, and it is 85% for plan 4 on the JTV, and it increased to 99.9% in the JTV core, whereas 63.9 and 50.1 for the original plan in the JTV and the JTV core respectively. The size of this modulated target and corresponding prescribed dose affect average LET. The modulation, as we see here, the modulation volume increase. As this increase happening in the modulation volumes, the average LET in the GTV and GTV core tend to decrease. Whereas for the prescribed dose to GTV and GTV core, from 67.5 to 100 gray, the average LET in both the GTV and GTV core start to show an increase. And the highest average LET region, which received more than 44 kV per micrometer, is located at the beam distal parts in the target, at the beam distal part in the target. Only in plan 4, where we can see the high averaged LET cover most of the gross tumor volume core, actually cover the gross tumor volume core totally and most of the gross tumor volume in general. So to conclude, both studies agree that average LET strongly depends on the target volume that is quickly increasing with decreasing volume. Average LET strongly change with tumor volume and beam arrangement. Average LET for carbon ion yield higher RBE and lower oxygen enhancement ratio than proton and proton therapy. Due to the range uncertainty, simultaneous integrated both and spot scanning hardening arc could potentially lead to overshoot in Oregon at risk. The hypoxic cells are located in the core of the tumor, and the side of the tumor would be less hypoxia. The better approach to increase beam average LET is the use of heavier particle such as neon and oxygen ion. However, it is very limited. Further research to evaluate and improve these strategies are needed. And with this, I come to an end of my talk. I'm happy to answer any of your questions. Arigatou gozaimasu.